Welcome to Anesthesia 101. I am Dr. Blackwell. Thank you for joining us today. We will be reviewing the trauma patient. And in the trauma patient, we will be reviewing the anesthesia role, the primary survey, anesthetic considerations, and fluid resuscitation and burns. Thank you for joining us for this today, but before we can review these important concepts of trauma, you must review and enjoy the video by Diamond Daniels Ninja School of how trauma can happen in an average American home. Thank you.
Welcome to Diamond Daniels Ninja Teaching School. Here is my little ninja. Ninja, you got her sign on there backwards. You need to turn it around. So, sorry about that. She's not been right since I knocked her in the head with the Judy chop. Today in the Diamond Daniels Ninja School Teaching School, we're going to go over the proper chopping. Alright, you got your Judy chop. And then you got your karate chop. And then you got your ninja chop. Now, it's proper to getting your proper stance whenever you're doing your ninja. Because another important thing is when you do your Judy chopping, you don't want to do your kung fu kicking because you got your Judy chopping.
Welcome. It is important for the anesthesia provider to remember that these patients may have an increased likelihood of being drug abusers, acutely intoxicated, or carriers of hepatitis or HIV. Thank you.
Okay, next in our Diamond Daniels Ninja School, we're going to break a board here. Do you see it right there? Hard as a rock. Alright, little ninja, let's put this down here. Remember what happened last time with you, okay? And you got your Judy chop!
Trauma remains the leading cause of death for individuals between the ages of 1 and 45. It is the fourth leading cause of death following heart disease, cancer, and cerebrovascular disease. 50% of trauma deaths occur immediately, with another 30% occurring within a few hours of injury, known as the golden hour. Head and neck trauma. The level of consciousness is assessed by serial Glasgow Coma Scale evaluations. Common injuries requiring immediate surgical intervention include epidural hematoma, acute subdural hematoma, and some penetrating brain injuries and depressed skull fractures. The classic Cushing triad of hypertension, bradycardia, and respiratory disturbances is a late and unreliable sign that usually just precedes brain herniation. Patients suspected of sustaining head trauma should not receive any premedication that will alter their mental status. Brain injuries are often accompanied by increased intracranial pressure from cerebral hemorrhage or edema. Intracranial hypertension is controlled by a combination of fluid restriction, diuretics, barbiturates, and deliberate hypocapnia. A slight elevation of the head will improve venous drainage and decrease intracranial pressure. Anesthetic agents that increase intracranial pressure should be avoided, such as ketamine. Mild hypothermia may be beneficial. Thoracic trauma. Trauma to the chest may severely compromise the function of the heart or lungs, leading to cardiogenic shock or hypoxia. Nitrous oxide will expand a pneumothorax and is contraindicated in these patients. Treatments include placement of a chest tube. Multiple rib fractures may compromise the functional integrity of the thorax, resulting in flailed chest. Massive hemoptysis may require isolation of the affected lung with a double lumen tube to prevent blood from entering the healthy lung. Cardiac tamponade is a life-threatening chest injury that must be recognized early. Next triad of neck vein distension, hypotension, and muffled heart tones, and pulsus paradoxus, and a high index of suspicion will help make the diagnosis. Myocardial contusion usually is diagnosed by electrographic changes consistent with ischemia. Other possible injuries following chest trauma include aortic transection or aortic dissection, avulsion of the left subclavian artery, aortic or mitral valve disruption, traumatic diaphragmatic hernia, and esophageal rupture. Abdominal trauma. Patients involved in major trauma should be considered to have an abdominal trauma until proved otherwise. Patients tend to fall into three subgroups: pulseless, hemodynamically unstable, and stable. Pulseless and hemodynamically unstable patients, those who fail to maintain a systolic blood pressure of 80 to 90 millimeters of mercury with 1 to 2 liters of fluid resuscitation, should be rushed for immediate laparotomy. Blunt abdominal trauma is the leading cause of morbidity and mortality in trauma and the leading cause of intra-abdominal injuries. Profound hypotension may follow opening of the abdomen as the tamponading effect of extravasated blood and bowel distension is lost. Nitrous oxide is avoided to prevent worsening of bowel distension. Massive abdominal hemorrhage may require packing of bleeding areas and/or clamping of the abdominal aorta until bleeding sites are identified and the resuscitation can catch up with the blood loss. The use of a mannitol infusion and a loop diuretic, along with resuscitation fluid, may prevent renal failure in such instances, but is controversial. Progressive bowel edema from injuries and fluid resuscitation may preclude abdominal closure at the end of the procedure. Oliguria and renal shutdown may follow. In such cases, the abdomen should be left open but sterilely covered, often with IV bag plastic, for 48 to 72 hours until the edema subsides and secondary closure can be undertaken. Orthopedic trauma. Extremity injuries can be life-threatening because of associated vascular injuries and secondary infectious complications. Fat emboli are associated with pelvic and long bone fractures and may cause pulmonary insufficiency, dysrhythmias, skin petechiae, and mental deterioration within 1 to 3 days after the traumatic event. A compartment syndrome can also occur following large intramuscular hematomas, crush injuries, fractures, and amputation injuries. The diagnosis may be made clinically or based on direct measurement of compartment pressures, greater than 45 millimeters of mercury or within 10 to 30 millimeters of diastolic blood pressure. A cooled amputated limb may be reimplanted up to 20 hours following amputation. A non-cooled part has to be implanted within 6 hours.
Hi, we have just learned about the different types of trauma. In this next video, we will see how a mountain man from West Virginia decides to dish out a little trauma of his own when his eggs don't come out just right. Thank you.
So I held that butcher knife up to her neck and I said, "Woman, if you want to live to see tomorrow, you better start frying up them eggs better than you've been frying them. I'm tired of eating them slimy, sloppy eggs. Now get in there and fry me some eggs. I love you, baby." Them eggs better be cooked right now. I want your cigarette. Woman, these eggs better not be slimy, sloppy eggs.
Anesthesia plays an important role in trauma. The anesthesia provider is a critical member of the trauma team. They must be available 24 hours a day. They must be able to take care of severely traumatized patients from the moment they arrive to the trauma center. Anesthesia can directly affect the survival of trauma patients. and anesthesia is primarily concerned with the management of the airway and ventilation during the initial resuscitation efforts. The initial assessment of the trauma patient can be divided into primary, secondary,